Today we are just going to review some basics of MRI of the ankle in terms of how to obtain the best images and also interpretation of some of the common pathology. Just to review the anatomy before we get into the MRI portion of it. As you know, ankle has 4 bones and is comprised of 3 joints: talofibular, tibial talar, tibiocalcaneal, with middle anterior and posterior facets, but only anterior and posterior subtalar joints. So we'll come to that. Just to look at the subtalar facets of the calcaneus, the anterior and middle facet comprise of the anterior subtalar joint, and the posterior facet will form the posterior subtalar joint with the talus. So just to remember, 3 facets, 2 subtalar joints. Coming to the ligaments, the medial collateral ligament of the ankle is comprised of several fascicles, as you can see here, which is also called the deltoid ligament, which is self-explanatory on this image. The tibiocalcaneal, tibiotalar, and anterior and posterior, in addition to the calcaneonavicular fascicles. In the MRI images, you can see the thick bundle of the tibiotalar ligament and more superficial tibiocalcaneal ligament. Tibiotalar ligament is always slightly more hyperintense or intermediate in signal intensity, not to be mistaken for tears. The lateral collateral ligament complex is comprised of 3 separate ligaments: anterior talofibular, calcaneofibular, and posterior talofibular. Anterior and posterior talofibular ligaments, as depicted on this axial MRI image, are more transversely oriented, as you can see, so therefore they're best seen on the axial images. And the calcaneofibular ligament is more obliquely oriented, more like in the coronal plane. These are the ligaments that are most often torn, the anterior talofibular ligament being the thinnest and the weakest is the most common one to tear. So again, this is the anatomical view once the more superficial structures have been removed, showing the lateral collateral ligament complex. And also here you have the peroneal retinaculum, superior and inferior, keeping the peroneal tendons in place. Moving on, we can also see a Lisfranc ligament, which runs obliquely from the medial cuneiform to the base of the second metatarsal on most of the ankle images. So when you're looking at ankle images, just make sure to glance in the region of the Lisfranc ligament to see if it is intact or torn. The tendons can be easily divided into 4 groups: the extensor tendons being the anterior, the flexor tendons being the medial, and the lateral groups, the medial tendons, the tibialis posterior, digitorum, and hallucis, the peroneus longus and brevis tendons on the lateral aspect. The one deeper is the peroneus brevis, and the posterior consists of the Achilles and the plantaris portion. Basically, you see it as one tendon here. And again, in the medial aspect, you see the neurovascular bundle, which is in that region of the tarsal tunnel. Typically, you want to use a surface coil. Usually, you get a knee coil with a kind of a chute to put in the foot. And T1 weighted images, you want to get at least one sequence of T1 weighted images in one plane. Because bone marrow evaluation is critical in ankle and foot images, because you can get many bone marrow abnormalities, as you know, ankle and foot being more prone to trauma. And proton density images are signal rich, and you want to have a few of those and a couple of T2 weighted images. Again, thin sections, 3 to 4 millimeter sections, typically with no gap. Just to show you the, how typical ankle images look, notice that the images need to have enough signal for us to evaluate the anatomical structures. So moving on, you can either start from outer structures to in, or start with the bones and bone marrow evaluation and move out to have this same sequence of anatomical structures we want to evaluate. Starting with the ligaments, typically anterior talofibular ligament is seen at the very distal tip of the lateral malleolus, where you see the malleolar fossa being concave in the medial aspect of the lateral malleolus. Here is the posterior talofibular ligament, and the peroneal tendons seen as one. Actually, there are two tendons. Again, showing the normal appearance of the tendons and ligaments. Here is the posterior tibiofibular ligament. Notice that this section is higher than the one you saw before, where you see the anterior talofibular ligament. Notice that the lateral malleolus is more bulbous here. So this is a higher section. Evaluating the bones, several things can happen in ankle and foot, traumatic injuries and abnormalities being quite common. Typically, you can see contusions, and also you can see insufficiency fractures in the foot and ankle when the plain foams are negative and you still suspect a fracture. You want to go on to an MRI and to evaluate the osteochondral lesions, most commonly seen in the talus, and also some of the talar bones are susceptible to avascular necrosis, as you know. And then extremity osteomyelitis in adults, especially diabetic patients, MRI is the imaging of choice. For the purposes of time, we are going to move on and show some examples of insufficiency fracture in the calcaneus. As you can see, the fracture line is low in signal on T1 weighted images, and bone marrow edema lights up in the fluid sensitive sequences. You can either use STIR or T2 weighted images. You want to use STIR images, especially in the extremities, because fat suppression may be inhomogeneous, especially if you're using a low Tesla MRI magnet. In a high field magnet, also you want to use a surface coil and use at least one STIR sequence so that you can evaluate if it is true marrow abnormality versus inhomogeneous fat suppression. Again, the same patient here. You see the same patient on the plain radiograph with very subtle, questionable sclerosis in March. However, moving on, in 2 months later, the sclerosis is slightly more prominent. However, there is no question on the MRI that there is definitely an insufficiency fracture. Coming to avascular necrosis, several reasons, causes for avascular necrosis, systemic, steroids, patients with rheumatoid arthritis on steroids, and other causes, hemoglobinopathies, can get avascular necrosis. Talar dome is typical location. This is typical appearance of septogenous low signal with adjacent high signal, and you can also have on contrast enhanced images, the portion of the avascular necrosis will not light up with reactive changes along the edge. Other causes of AVN, as you know, are talar neck fracture, especially displaced talar neck fractures are more susceptible for avascular necrosis because of their blood supply. As you know, the talar head is supplied by tenuous branches from the peroneal and dorsalis pedis artery. Therefore, when the talar neck fracture is displaced, the talar head tends to get avascular necrosis. And other bones that typically have AVN or the navicular and metatarsal heads. This is another example of the entire talus with AVN, a low signal on all pulse sequences, and if you were to give contrast, there will be no enhancement. Moving on to osteochondral lesions. Typically, again, osteochondral lesions are secondary to trauma in the foot and ankle, and talus is the most common, talar dome is the most common region that you see OCD. And in terms of MRI evaluation for osteochondral lesions, you can also do intraarticular injections in order to see if the osteochondral lesion is loose or detached or partially detached. The contrast, if there is any detachment, contrast will seep in between the fragment and the donor bone to delineate the extent of detachment, so you can easily evaluate if it is a stable or an unstable osteochondral lesion. CT can also be used to evaluate osteochondral lesions. Again, there's different stages like we already talked about. You can do MR arthrograms if stage 3, 4 lesions need to be distinguished. Okay, I'm just going to run the video clip on this. So I'm going to move on since I do not have any live participants right in front of me. This is an example of a tarsal coalition. Common sites of coalition are calcaneonavicular, and in this, as you see in this talocalcaneal, the middle facet is the most common to have tarsal coalitions. Plain films can also be helpful, but many times, it's difficult to look for tarsal coalition on the plain radiographs, especially if they are fibrous or cartilaginous coalition or versus osseous coalitions. So CT or MRI would be the imaging of choice in tarsal coalitions. You suspect tarsal coalition when you have a young patient with persistent chronic foot and ankle pain with no known etiology or no known significant trauma, and that's something you want to think about. Here is an example of non-osseous coalition. It's hard to distinguish between fibrous and cartilaginous coalition, so typically I describe this as a non-osseous coalition. Talar beaking is also supposed to be one of the clues to look for tarsal coalition, although it may not pan out most of the times. This is an example of calcaneonavicular coalition. Typically, anterior process of the calcaneus is sharp and small. Here you see almost like a pseudoarthrosis. Here are like a facet for the anterior process for the calcaneus. I shouldn't say pseudoarthrosis because this is a true joint. Anyway, you have bone marrow edema in the adjacent bones at the navicular calcaneus, and also to some extent in the talus adjacent to the sinus tarsi. Moving on to other etiologies, other pathologies in the bone, like we said, osteomyelitis, specifically in diabetic foot. MRI is an indication to image patients with suspected osteomyelitis. Typically, you look for low signal on T1 weighted images and marrow edema on fluid sensitive sequences. Low signal on T1 is supposed to be more specific because you can see reactive edema even in the absence of osteomyelitis with adjacent cellulitis or soft tissue abscess. So you really want to look for T1 weighted images. Once again, very important to have small field of view signal rich images in order to evaluate these small areas, and also in order to give accurate diagnosis. These are contrast enhanced images of the same patient. As you can see, quite extensive enhancement of the involved fifth toe. However, need to keep in mind, especially now, because of NSF, you do not want to give contrast in many of these diabetic patients where creatinines are, their GFRs are low, around 30 or 35. Many of these patients do not get contrast, so you may have to rely just on the non-contrast enhanced images in order to diagnose osteomyelitis. Okay, we are going to move on, and coming to soft tissues, talking about ligaments. We talked about anterior talofibular ligament earlier. This is an example of an anterior talofibular ligament tear. You can see a small avulsed bone fragment here when the anterior talofibular ligament tore, and the normal thick fibers of the posterior talofibular ligament. So what are the things that we look for in ligament injury? You want to see a single straight line of low signal in all pulse sequences. So if there is interruption, portion of or the entire ligament is not visualized, laxity or waviness, thickening, and also surrounding signal changes. Once again, here you have a normal anterior talofibular ligament, abnormal anterior talofibular ligament. Again, a torn anterior talofibular ligament with fluid extending where you would expect the ligament to be. Now coming to tendons, um, when you see small amount of fluid in certain areas around the tendon sheaths, it may be normal. Typically, some fluid around the flexor hallucis is normal, that is extension of fluid from the joint. Peroneal fluid is variable and communicates with tendon sheath, and small amount of fluid in the proximal portion of the tibialis posterior tendon is also normal. However, fluid in the distal portion of the tibialis posterior tendon is always abnormal, and also fluid in and around the Achilles tendon is also abnormal. And this is an example of a chronic tear of the posterior tibial tendon. You can see intrasubstance signal within the tendon, and there is also some adjacent soft tissue changes. Typically, posterior tibial tendon tears are a long drawn process, and they're chronic tears. You can have split tendons. You can see two tendons instead of one, with a longitudinal split of the posterior tibial tendon. You can see thickening, and of course sometimes you can see complete tear of the tibialis posterior tendon. This is another example of a thickened, very abnormal tibialis posterior tendon with a lot of intersubstance signal near complete tear. Now, just to show you where the tibialis posterior tendon lives, this is the flexor retinaculum, which keeps the tendon in place, and bulk of the tendon attaches to the inserts into the navicular, with additional slips going to the cuneiforms. Now, as you know, posterior tibial tendon is a dynamic stabilizer of the medial arch, and once the tendon tears, the medial arch starts to fall apart, and you can get planus deformity. And as it progresses, what happens is the calcaneus subluxes or rotates laterally, and then you can get lateral impingement secondary to a chronic posterior tibial tendon tear, and this so-called lateral high foot impingement or an extra-articular impingement can be confusing, as patients can come in with a posterior tibial tendon tear but complain of pain laterally. Just to show you how this happens, typically in normal alignment, the lateral process of the talus and the calcaneus, there should be a small gap. Once the posterior tibial tendon tears, there's nothing holding the calcaneus in place, and starts rotating laterally and impinges on the lateral process of the talus, and you can get marrow edema. And further on, the calcaneus subluxes laterally and again impinges on the lateral malleolus, and this is how you get lateral impingement. So what happens is the soft tissues get squished between the lateral malleolus and the subluxed calcaneus, and you can get peroneal tendon subluxation and soft tissue impingement and lateral pain. So this is the hind foot angle that is being measured. It can be tricky in MRI. Usually you drop a line along the long axis of the tibia, and along the medial margin of the calcaneus. But again, where to draw this line is also can be tricky because the calcaneal line should be drawn between the sustentaculum and the calcaneal tuberosity. Now, this is an example of an extraarticular lateral hindfoot impingement secondary to posterior tibial tendon tear. As you can see, there are a lot of marrow edema in the talus, calcaneus, and also the lateral malleolus and the soft tissue edema secondary to the impingement, as opposed to a normal anatomy here. Lateral malleolus, the peroneal tendons being in normal position here, and the lateral process of the talus and calcaneus. Coming to posterior group of tendon, basically you're talking about the Achilles tendon, which is one of the largest tendons in the body. Typically, older individuals have Achilles tendon tears, those that are not conditioned and start exercising. Also, patients who have systemic problems such as diabetes tend to tear Achilles tears. Now, we can have either acute or chronic tears of the Achilles tendon. Typically, the tears or acute tears are seen a few centimeters proximal to the insertion, and while imaging for a suspected Achilles tears, you want to have several centimeters, at least a few sequences above the level of the ankle, so that you can see the cut end of the tendon. And it's important in complete tears to see what is the fluid gap, what's the distance of the fluid gap for the surgeon to know when they want to repair the Achilles tendon. Now, chronic abnormalities of Achilles tendon can also be seen, such as thickening, intersubstance signal, and eventually these can tear. Partial tears can be seen as thinning of the tendon versus complete tears being showing a fluid gap. This is an example where most of the deep fibers are torn with a few superficial fibers being intact and holding it in place. So this is almost about to completely rupture. Again, axial images showing some of the intact superficial fibers. And this is as opposed to the partial tears. I see a complete fluid gap here near the insertion, suggestive of a complete tear. You can see that the Achilles tendon to begin with does not look abnormal, very thickened, and also has intermediate signal intensity and with some linear high signal, showing that tendon was abnormal to begin with. Now, again, associated posterior ankle pathologies. Certain type of patients can develop posterior ankle pain. This is one of the common causes, so-called thumb bump. Here you have Achilles tendon tear and also some marrow edema with mild Kager's fat pad signal abnormality, and I'm not sure we have the correct one to show the retrocalcaneal bursal fluid. This is somewhat similar to Haglund's deformity or thumb bump with Achilles tendon tear. Now, moving on, peroneal tendon tears are associated with inversion injuries and ankle sprains. Persistent swelling along the peroneal tendon sheath is a good indicator for peroneus brevis tear. And as you can see here, the normal course of the peroneal tendons, there are several twists and turns, and it is in a tight space bound by the superior retinaculum and the inferior retinaculum and a bone as the floor for the peroneal tendons. So any of these can injure or sublux the peroneal tendons, including the retinacular tears. And typically, you want to look for the tendons tucked behind the lateral malleolus, and the peroneus brevis tendon runs anteriorly and deep to the peroneus longus tendon, and the peroneus longus tendon dives down to under the foot to attach to the base of the first metatarsal, whereas peroneus brevis attaches to the base of the fifth. Again, you see the normal peroneal tendons here. You can also see normal variations such as the peroneus quartus. Typically, you don't see a muscle belly below the level of the lateral malleolus. Here you have a peroneus quartus. Just to review the tendon pathology and the terminologies used, we do not use in MRI the term tendinitis. Tendinitis is more a clinical diagnosis and a pathological diagnosis to see inflammatory cells in the tendon. We call intermediate signal or abnormal configuration of the tendon, such as thickening as tendinosis or tendinopathy, indicating degeneration of the tendon, typically a chronic process. And then typically the partial tears are type 1 and 2, type 3 denoting a complete rupture of the tendon. Tenosynovitis is abnormal fluid in the tendon sheath. That is inflammation of which indicates inflammation of the tendon sheath. And if you were to give contrast, there is also going to be enhancement of the synovium or the tendon sheath. And peritendinitis and peritendinosis used for tendons which do not have a sheath. For example, Achilles tendon, you don't want to use tenosynovitis because there is no enveloping sheath for Achilles tendon. And I think we will stop here in view of time, and I'll take any questions if you have.